John, how do we start this? You said what's bigger than you just had an earthquake?
Yes, we did. The first one in Brooklyn that I've ever witnessed, and I
Yeah.
survived.
I was in LA earthquakes, John. We'll have to talk. Let's hear more about that in the show. But here's a way to start, John. You remember how Dak Prescott starts the Dallas games?
Well, Dak, does he ever start? Or no,
Yeah.
he
Here
just
we
doesn't
go.
finish.
Here we go, Kristen. Here we go.
Welcome aboard Lifelines with David and John, your guide to charting the transformative course of crisis intervention and the game-changing 988 Lifeline.
We're your hosts. It's if crisis is your jam, Dr. John Draper is your guy. I'm David Covington, and John, we were crisis back when it wasn't cool.
Yeah. No, we really worked really hard to make it cool, David. I'm not sure we're there yet. But now that Richard's here, it's totally cool.
Well, watch us on YouTube, like and subscribe, or wherever you get your daily dose of podcast. We're brought to you by Behavioral Health Link, and episode 2 is going to be fire, John. Brooklyn, tell us about our amazing guest and the story for today.
Well, first of all, my story is about this earthquake. I got to get to that first, because
John, what was the Richter scale of this?
It was
It's got to be a
4.8.
5 for you to have time in the crisis.
No, it was 4.8.
Lifeline podcast.
It was 4.8, and it shook everything in the room to a point where I said, I've never had an earthquake here before, ever, 30 years plus here. So I went downstairs to see what was going on, and I saw some construction workers outside. I thought maybe they were drilling something. So I went outside, and remember, David, this is Brooklyn. So I walk up to these Brooklyn hard hats, and I said, so are you guys drilling? They said, no, we're just sitting around talking. And I said, so did you feel that shake? It felt like an earthquake. My whole house shook. And they just laughed at me and said, I didn't feel anything. Oh, yeah, Fat Bobby over there fell down. Maybe that was it.
Oh, no.
That's what they say here in Brooklyn. But I can tell you, 4.8, it shook things up and broke some of my favorite pictures over here.
Well, look, 988 has been a 7.0 on the Richter scale, John, in transformation for the field, and our guest has been right at the heart of that.
Absolutely. We are so delighted to have you here, Dr. Richard McKeon, the Senior Advisor for the 988 office at SAMHSA. Richard, say hello.
Hello, it's a pleasure to be here and a pleasure to be talking with both of you, John and David.
Well, and Richard, our intent today is to go through this long and winding road of 988 and crisis care. And but before we do that, we want to get into a little bit about you to set the stage for people who most people do know you, Richard. So maybe tell us something that folks don't know about you.
Okay, so one thing that folks may not know about me, in addition to the fact that I'm a tennis player, would be that when I first came to Washington, D.C., I was an American Psychological Association Congressional Fellow, and I worked in the office of U.S. Senator Paul Wellstone, who was an incredible champion for mental health parity, working on the Wellstone-Domenici mental health parity. Well, parity is now the law of the land. But he was also a passionate advocate for suicide prevention and passed the first youth suicide prevention bill along with Senator Chris Dodd of Connecticut, and directly related to our topics today.
Yeah.
It was Senator Wellstone who arranged to have the first $3 million appropriation to network and certify centers across the country under a single number.
Terrific, Richard. Richard, the other thing I was thinking about that some people may not know, this week you were at the SAMHSA Policy Academy, and
Yes.
You and Paul Galdis were running out for a taco or something because that's your old stomping ground.
That's true. Yes, I was a graduate student in clinical psychology at the University of Arizona in Tucson. an incredibly beautiful city with magnificent saguaro cactus. So if you've never been to Tucson, it's really a great place to go to visit. And yes, Paul and I did run out to get some authentic Mexican food for lunch on one of the days that we were there. And the Policy Academy itself was great. It was on design of crisis systems, and there were multiple states, territory, and tribal nations who were represented at the Policy Academy. So it really was very well done.
This is an Atlanta, Georgia based program, and we'll get to our sponsor in a moment. But I understand Wendy Tigreen was there as well.
She was. She was there, so we were very glad to have her and to have her talking about some of the tremendously relevant learning that she'd done in the state of Georgia.
Richard, the other thing we do to launch off with our guests is to see what they're a super fan of. And you've already leaned into this a little bit. I got my Spartan man back here in the background, but John Draper, I'm becoming a super fan of Formula One. John's a super fan of Taylor Swift. You went to the Taylor Swift concert.
Well, yeah, I wasn't until I went, and yeah, she's my daughter dragged me there, and now I'm a Swiftie.
Richard, John and I are going to take a second. I'm going to write down. You already teased into. I'm going to write down what I think Richard's answer is going to be on what he's a super fan of.
Right. I'm going to write that down too, David. Let's see if we can compare.
And then, Richard, we're going to show ours at the same time, and you tell us what you were actually going to say. John, you ready?
Yeah, hold on. Okay,
John, ready? 3, 2, 1. New York Yankees. I wrote softball. It's in the same genre.
Yeah.
It is.
Okay. So maybe he's going to say tennis, though, because he talked about so, Richard, what are you a super fan of?
Well, I mean, I'm certainly a super fan of softball and of the New York Yankees. But what I was actually going to say was University of Arizona basketball.
What?
So I'm still recovering from the Sweet 16 loss. But
oh my gosh, I've never heard you mention that before, Richard. Well, I'm sorry to hear that.
Did you see the electrifying game, Richard, between Caitlin Clark and Angel Reese, LSU and Iowa?
Yes, I actually watched it while at the Policy Academy earlier this week.
Richard, we are promoting the sponsor of this show is Behavioral Health Link, and I am wearing I think it might have been one of my very first trips to Atlanta, John Draper, as I ran the Peachtree Road Race when I was I guess I would have been a sophomore in high school, down the streets from the mall up there in Midtown, what is that, Buckhead, all the way down to 10th Street back many, many years ago. But John, tell us about our sponsor today, and let's bring up that visual and hear about the Crisis Software Platform.
Well, thanks, David. You know, I'm so glad Richard's here, because whenever I think of you, Richard, in 988, I think of that quote of yours about how 988 is going to transform crisis systems everywhere. And David, when I think of you and 988, I think of how your promotion of the idea of air traffic control in crisis care systems has been transformative. And it's been revolutionary, David. I mean, when you think about air traffic control, what is it? It's making sure that controllers never lose sight of planes and their precious cargo in it as they sail safely across bordering airspaces, making sure that they land in the safe place. And all of that is utterly reliant on seamless and reliable communications technologies. And we got the same goals in our crisis care system, David. And from the moment we say hello on call, text, or chat, to the moment that they receive mobile crisis outreach, to the moment they're feeling safer or calmer or connected to supports in their community, BHL software modules provide all of that communication technology, from helping out call centers, mobile crisis dispatch, follow-up, outpatient scheduling, and bed registry. It all accomplishes this goal of making sure that no one gets lost in the system. So, David, for any information, folks can just go to our website, learn more about it at behavioralhealthlink.com.
Richard, what did you ever think that John and I would actually land up working together? We were together for almost 20 years before that happened, John.
Yeah, we were dating all that time, but now we're married.
Here we are, Richard. Hey, Richard, our first segment is the good news. Good news, and it's good news, but the RAND Corporation with their research report said we've got work to do on the road to 988 and 911 interoperability, and maybe we can get a quick glance at that report, which came out, Richard, a couple of weeks ago now.
That's true.
Road to 988, 911 interoperability. RAND looked at three different cities, states, and just co-location, call transfer, and community response. Richard, did you see this report? Any reflections on the work that they chart ahead?
Well, I think that they're certainly highlighting a hugely important area, the need for coordination between 988 and 911. And as they point out, there are different models for doing that, and some of the places that we're familiar with, and I've visited a number of these programs, at the Harris Center, where you have counselors from the call center who are embedded in the Houston PSAP there to be able to directly work with callers who come into 911, to other programs such as D.D. Hirsch's in Los Angeles and Behavioral Health Response in St. Louis, where it is a transfer of the call from 911 to 988 based on clear criteria.
Yeah.
Because this is a critically important bi-directional relationship. We think that there are many, many people who contact 911 whose needs can be served through 988 or by transfer at least to a 988 call center. On the other hand, there are times where a 988 center may need to rapidly engage 911. The most obvious example of that is when there is a suicide attempt in progress.
Right.
And then those systems have to be talking to each other. They have to be cooperating with each other. They need to be based on a shared understanding of the role and potential for both 988 and 911, and have a way of reviewing whether problematic cases that may come up, sharing data, etc. One thing that's relevant in this way is that soon the National Emergency Number Association's 988 and 911 standards will be coming out, and they are NINA is a voluntary standard setting organization for the 911 PSAPs. So that will be an important contribution as well. But a lot of work that needs to be done in this space. I should also mention that at SAMHSA, we have a policy academy group that is working on exactly this issue, when to call 988 versus 911, with a technical expert panel looking into this. Vibrant's also been working actively in this space. So a lot going on and a lot that needs to go on.
And part of the complexity, Richard, is the number of centers. So about how many Lifeline 988 centers do we have, and about how many 911 PSAPs do we have? Do we have a sense of the difference in those sizes?
Yeah, the number of PSAPs is significantly more than our number of call centers. We have over 200 988 centers at this point. I think we are at around 220, but the number of PSAPs is tenfold that, if I understand correctly. But it's so, the one of the challenges is that if you are a center, let's say you're D.D. Hirsch in Los Angeles or the Harris Center in Houston, you're not only talking about a Los Angeles or a Houston PSAP, you're talking about PSAPs in the surrounding areas.
That's right.
And so for the 988 Center to establish relationships with all of the relevant PSAPs is a challenge for sure, just because of the scale and the significant number of PSAPs that are out there. Part of the reason why things like the development of the NINA standards are important, because it's going to be hard, or it's going to at least take a long period of time for every 988 call center to be in connection with every PSAP.
It's funny you mentioned LA County. John, there are 80 911s in LA County and 20 specialty dispatch 911s just in LA County where DD Hirsch is.
Yeah, there's, and again, this is a huge challenge just to technically interoperate and making sure we can get some of the major ones, the ones that get the most calls perhaps, and maybe that's the way to prioritize. But Richard, from your standpoint, and I know that we both have been engaged in talking with a lot of folks at 911, and I wonder if you could share with the people here who are listening, what have you been hearing most from the folks on the 911 side about what they like about interoperability? What's in it for them?
Yeah, I think that there is a recognition that there are many people who are calling 911 whose needs can be served through 988. And one of the key issues there, I think, of course, is that 911 is dependent on being able to provide rapid response. Right. And so that means that they can't spend a lot of time talking to folks on the phone when they're calling in. And of course, that's an important piece of 988, right? Is that, yes, if there's a suicide attempt in progress, we have protocols about what to do next and so forth. But when somebody is, and of course there are a range of issues that someone can call 988 about, but if somebody's having thoughts about suicide, having somebody who can listen, who could find out what's driving those suicidal thoughts, and can work with the person on a safety plan, on trying to meet their needs, that takes a little bit of time, right? Yeah. And it's not just about a rapid dispossession. And of necessity, that we expect, if you need the police to come because you think someone's breaking into your house, you want that to go quickly. If there's a fire, you want that response to be quickly. You need an ambulance, you want that to be quickly. So that time urgency in the 911 part, it's not that there's not time urgency on the 988 part, but it's designed to be able to talk with people and to know enough about people in suicidal and other kinds of crises to not panic, right? To not get so anxious at the word suicide, but to realize that there are different levels of risk, that you can talk to somebody and you can get a sense of, is this somebody, for example, who there are people who have had suicidal thoughts almost every day of their life, but have never acted on them. Yeah. Very different from the person who has made a plan or has lethal means available. Those are very different circumstances that may call for different responses.
And Richard, what you're highlighting there, which is so important, is that when you phone 988 and talk with a counselor, that itself is an intervention. When you phone 911, what people are looking for is not necessarily to connect to a person, but connect to police, fire, or medical response. That's what they need. And so when they need to talk with somebody about their problem, they need to call us.
I visited Austin, Texas not too long ago and met with folks from the 988 Center there, Integral Care, and visited with their EMS folks. And in Austin, when you contact 911, you'll get a choice. Like the question that you hear is, do you need police, fire, medical, or mental health? Fascinating.
Breakthrough, Richard.
To see how that would, how that would be there. So a lot of really important work going on and that needs to go on in this space.
So, Richard, our episode today is about the history of how we got to this transformative point of 988 and the picture forward. And we're going to start with our podcast, our Lifelines trivia. It's a little different here, Richard. Instead of the Who Wants to Be a Millionaire approach, we're doing an over-under. And John, you're in the over-under seat, and Richard gets to say over or under. John, you're 0 for 1. If I remember, not that they're winners.
I'm going under all the time, David.
It's not that it's a competition, John, but I think you're 0 and 1. Just saying.
But who's counting?
Let's bring up the over-under slide for today. And Richard, you referenced going all the way back to Paul Wellstone. In 1998, there was this breakthrough event in Reno that really paved the way for Surgeon General Satcher to declare suicide a serious public health problem and for us to have a national strategy. How many people, John, researchers, advocates, lived experience providers were at the Reno conference in 1998? How many people were there, John? Richard, were you there?
I was not. I am familiar with it, though.
Jerry Reed, DeQuincy Lazine. We certainly know people who were there. John, how many were there?
It's a legendary event, but I really have no reference point, David. But I don't think it was anywhere near the kinds of numbers that we're seeing at AAS now. But it was a good proportion of people. A lot of suicide survivor and lost survivor groups there. So I would say 400.
Wow, what a guess. All right, Richard, over or under? It was more than 400 or it was under 400?
I would say under.
You know, I would have said under, Richard, but last night I was looking this up. I could not find the answer, and I texted DeQuincy Lazine, and he sent me this flyer. Let's go to the bottom of the flyer, Karen. And more than 450 people furnished 290 ideas for recommendations to a select expert panel of 10 and their chairperson who gleaned a draft preamble and 81 recommendations for the national strategy. And Richard, of course, you led with Dr. Jerry Reed the revision of the national strategy in 2012. And again, last year and this year, the second revision of the national strategy.
Yeah, that's correct. Actually, the 2012 strategy, Jerry Reed was the private sector co-chair. The public sector co-chair was Surgeon General Regina Benjamin.
Right.
But I was very glad to be able to play a role on the coordinating group for that, particularly on the ones having to do with treatment. And then currently, I'm part of the National Strategy for Suicide Prevention Project Management Group, which has been co-led by Brandon Johnson from SAMHSA, Deb Stone from CDC, but also includes myself, Jane Pearson, Joel Dubinitz from ASPE, Judy Qualters from CDC. But my role has been on helping to oversee the treatment and crisis component, that strategic direction for the revised national strategy.
John Draper, I stand corrected. You're on a roll. That was excellent.
Yeah, neck and neck, 1-1. We'll see how far down I go next week.
Richard, John went with Delilah to the Eras Tour, Taylor Swift's global domination event. And today, we're not looking for any wardrobe changes from you, but we would like to do an Eras Tour of crisis with you, Dr. Richard McKeon.
But feel free to change if you need to, Richard.
Yeah, if you need to. So we're going to go all the way back and start era one, Richard, that period from 1958. You referenced Didi Hirsch, the original Los Angeles suicide prevention line that led to a proliferation of crisis call centers across the country. And we'll start that next phase with 1998 and the Reno conference. So that period from 58 to 98, Richard, and the Atlanta call center started in 1966. So they were starting all over the place. What are your reflections on that era, Richard, and what you've learned about the work that was being done during that time? What were the opportunities and the challenges?
Well, as you said, it was the era where hotlines first began in the United States. So hugely important, the LA Suicide Prevention Center, which is now Dee Dee Hirsch. One other thing, though, I would mention was that I think is important to note during this time period was in 1963, the passage of the Community Mental Health Centers Act signed into law by John F. Kennedy. And one of the things about the Community Mental Health Centers Act was that there were 5 required activities for every community mental health center, one of which was emergency services. So that was an important federal initiative to try to promote emergency and crisis services in the community. Because when you look in the 1950s, what you would have been talking about were ways in which people were being brought to state hospitals.
Right.
So having community-based mental health resources and having crisis being a part of that, crisis and emergency, I think is a very important area. And then, suicide prevention during that era was slowly growing. There was Ed Schneidman at the National Institute of Mental Health, the formation of the American Association of Suicidology, and the beginning of a more focused attention leading to, said, the Reno Conference in the late 1990s, and where I think that was also associated with the passage of a resolution that passed unanimously in the U.S. Senate that basically said suicide is a national problem. It requires a national solution, and there ought to be a U.S. national strategy for suicide prevention.
Yeah.
Hey,
Which then the Reno Conference was instrumental in helping to provide input into.
Richard, I was curious as you were going through that really important, really pre-21st century era from 1950s until 1999, and with the Reno Conference and Dr. Satcher's publication of making suicide prevention a priority for the government in 1999. What would you say, how would you describe how suicide prevention was primarily done and addressed in behavioral health care all the way through the 90s?
Well, I think that the way in which it was addressed was not very directly and not very explicitly. I think there was a view on the one hand that mental health as usual, mental services as usual could deal with this, but at the same time there was a profound pessimism about being able to prevent suicide.
Yeah. This idea that suicide's inevitable, Richard.
Right.
That's right. And the statement that you would hear people say at times was that if somebody's really intent on killing themselves, you can't stop them. And of course, that's something that's easily misinterpreted.
Yeah.
Obviously, the best suicide prevention is engaging somebody who's at risk and keeping themselves safe.
Who was doing that in the 90s, 80s, 70s, and 60s?
Well, I mean, I think that what you were having more of is reliance on inpatient hospitalization. At the time, there was not even an awareness, I think, at the significant number of people we lose after discharge from leaving inpatient units.
But John, the crisis centers that we're starting to develop, they did have that view. Richard, one of the things, Richard, I was surprised by as I was researching last night and trying to find out how many people were at the Reno convening, I found a timeline, and it showed that AAS certified its first crisis center in 1976. If that had been a trivia question, I would have said 95 or 2000 or even 2001 or 2002 as the as you began to work with them in a formal way with 1-800-SUICIDE. So did you know that, or were you surprised by AAS beginning to certify crisis centers that early on?
Well, I think that because I joined AAS, I think it was 1992, and they already had a well-established certification program. And in fact, that was part of what drew me to joining AAS, the fact that they had that focus. But part of what was happening at the time was that the call centers were, not all the time, but a lot of times, were disconnected from the mental health and healthcare systems.
Right.
Right. And so these call centers were there doing it on their own, right, and having to deal with it. In fact, in some places, the local mental health center would turn over their phones to the local call center, to cover crises after hours.
Right.
But you mentioned like how was the working in those days, and one other thing I would mention was that the challenges we've had in terms of training of health and even mental health professionals in suicide prevention. I often tell the story that in 4 years at an American Psychological Association approved graduate program in clinical psychology and a year in a Yale predoctoral internship, I was only exposed to one lecture on suicide prevention.
I know you gave that lecture, Richard.
I bet you do. You've heard me tell the story before. And the one lecture I heard was the one lecture I gave, because I had a graduate school teacher who said, pick a topic, present to the class. I picked suicide and presented on it, but literally that was it. Now, at the same time, of course, we would have placements and we'd be working with suicidal people. So yes, we would talk in supervision around people who were suicidal and what they needed, but it was not part of the curriculum at all.
Yeah.
Now, currently there are great programs that provide that kind of training, but it's still not universal across all the places. So if you think of a place like Catholic University and Dave Job's program, that provides excellent training, but it's not standard for any of the mental health professions, not required.
So John, this is the point, John, where we now do a wardrobe change and a set change. And we're going to leave that period of time and move into the next
before
period.
We do that, let me give a quick summary, because I think this is really important what you're saying, Richard, and that is that suicide prevention was not really a part of community mental health centers. It was very much a part of crisis hotlines. Crisis hotlines were not a part of the community mental health system. So that's what we were entering into the 90s, going into the 21st century.
And I'll add one more, John. The crisis call centers, with some loose connection through attending a conference or being certified, had very little professional orientation or connection until this next era. And Richard, the next era, there's a national strategy, but there's also SAMHSA's engagement of a national suicide prevention what was at the time 1-800-SUICIDE. And a plan to certify crisis centers across the country and move them. So we began to see a set of guidance and direction and national connection. So talk a little bit about that era from 98 to 2005.
Sure. So, in 2001, when the National Strategy for Suicide Prevention was released, there was nothing about hotlines. There was virtually nothing about treatment or the role of the healthcare system, right? There was lots of good things that were in it. One of the objectives was to establish a suicide prevention resource center. Another was to establish a national action alliance for suicide prevention. So there were many good things in it, but this was left out. But 2001 was also the first SAMHSA grant to network and certify centers. So that was when these various centers all across the country first got united into a single system, answering calls with also a system for certification, which at that time was mostly AAS certification as well. Then, we had then in 2004, the first time the Hotline grant, which had been awarded in 2001, was recompeted in 2004. And that was when then the Mental Health Association of New York City successfully competed for that. And in 2005, the 1-800-273-TALK number, the National Suicide Prevention Lifeline, was formally launched.
So, Richard, that period is also when John and you first met, and I and you first met. So, John, tell your story first.
I mean, Richard, do you remember our very first conversation?
Yes.
Tell me
there are a number of unsung. This story has a number of unsung heroes. People like Steve Eleazon in Utah, but another one is Brenda Mannix. She was Brenda Brune at that point in time. And, Brenda told me that we need to get the word out that this grant is being recompeted. We want a strong competition. And so, she said, I need you to make calls to let folks know. And one of those calls that I made was to John. At that time, I think you were running LifeNet.
Yeah, I was.
There. And, I was also visiting locals. I was in places around the country in different call centers who had been part of the network to let them know this is what we're doing. We're having this competition. We want you to stay engaged, et cetera. So that was, and so.
Well, I could do one better, Richard. Actually, we talked before that. And so you called me about 20 years ago to date. It was in the spring of 2004, and you called me up and your question to me, I don't know, you must have surveyed a number of crisis centers on this, but you called me as the director of LifeNet in New York City. You'd heard about us because of our response to 9/11, and you gave me a ring and you said, John, what do you think about the number 1-800-SUICIDE as a suicide prevention lifeline number? Do you remember that question? That conversation?
Well, I remember that we were giving a lot of thought to that. And in fact, in 2004, our notice of funding opportunity at the time indicated that we wanted, I think the phrase that we used was a life-affirming number.
Right.
To be utilized.
Do you remember what I said when you asked that question?
Actually, I don't remember what you said, John.
Well, I said I don't like the number 1-800-SUICIDE because it only focuses explicitly on suicide, and we need to have a number that's going to get people further upstream and one that gives them hope. So it was very much along those lines. But interestingly, as I was thinking about our first conversation, which was about a number, and that our first job together was to launch a new national number, which became 1-800-273-TALK, that 18 years later, as I was leaving the Lifeline work as an administrator, my job was to work with you to launch a new national number.
Yep.
And Richard, when did we first meet? Was that 2003 or 2004? It could have even been 2002. I'm not sure. I think it was 2002 because was that when Willie's coming on the show, John, as a guest, but Willie was a part of the Fulton County Crisis Line back when that original number launched in 1966. They were co-located with the Fulton County 911, and we were transitioning, but there was some confusion with the 1-800-SUICIDE folks. Is that the first time we met, Richard?
Yes, that was the first time that we met, and it was about let me put it this way: assuring there was coverage in the state of Georgia.
Yeah, so I had noticed that our data, we were the default coverage for the area code of Savannah, Georgia, and Atlanta, Georgia. I've still got that 404 area code. We covered 404, but the rest of the state went to another organization, and that other organization had dropped out. And we learned it because our calls from 1-800-SUICIDE spiked. And we had a discussion, Richard. So, Richard, amazing time, but really the period of time the three of us worked together and got to meet so many amazing people that I began to come into the work that the two of you were doing was in that next era, Richard, the 1-800-273 talk era that you and John were teeing up. And Richard, that was, I think, 1-800-SUICIDE, even given what it was, John still began a process of connecting through a national network and a national conversation. But 1-800-273 talk took it to another level. And Richard, talk about what in your mind were some of the main innovations that occurred during that 2005 to 2015 to 2020 kind of time frame.
Absolutely. And I think one thing that I would really emphasize was that, during that earlier period, there was a series of evaluations that were going on, right? That when the first funding came for the national network and certification, there was also an evaluation component. And people like Madeline Gould and John Califat and Brian Mashara were all doing evaluations. And that was really, that helped us, go past a critical threshold, right? That those studies were published in 2007, and we learned a tremendous amount. And one thing that was key important, and I think it's a lasting part of John Draper's legacy, was to take those evaluation findings and to work to incorporate them into the national network. And one of the things that was so wonderful about all the call centers is how responsive they all were, to that. And, that led to the establishment of standards for suicide risk assessment,
right?
Guidelines for callers at imminent risk, and the promotion of follow-up. Another major thing happening during that era was the establishment of a committee structure. And let me mention two things. And the first Lifeline Steering Committee was co-chaired by the New York State Mental Health Commissioner, right? So this was really the beginning of building links with the mental health and healthcare system. And then the other part was that there was a lived experience committee chaired by Eduardo Vega that began to provide input. One of the first documents on survivors of suicide attempts was supported by the work of the Lifeline. And in fact, if you look at things like the guidelines for callers at imminent risk, Eduardo Vega is one of the co-authors,
right,
around that. So it was a unique example of working together. So it was evidence informed because of the evaluations. And of course, the evaluation processes continued after that. It was incorporating the voices of lived experience, and it was building deeper connections to the health and mental health care systems, all hugely important innovations.
And Richard, you may remember that when we competed for the national grant in 2004, we came into the grant with the partners of the National Association of State Mental Health Program Directors. So they've been with us, and the idea of integrating suicide prevention and crisis hotlines into behavioral health care systems across the country started with a partnership between the Lifeline and NASHPD. And to your earlier point about evaluation, we also partnered with, going into that grant, John Califat and Maddie Gould. So it was all part of the package that SAMHSA was taking in. And it was a beacon for us in 2005 to have those evaluation findings that had been ongoing for the 3 years previous. I inherited those findings as basically on my desk. John, here is the way forward. Here's what tells us what works and what doesn't work and what we need to do better. But what was really good was to get a call from Eduardo Vega in 2005, who said, here's what you're not doing, Draper. Let me tell you that your Spanish hotline, one, doesn't exist, and two, it needs to happen today. And I said, I love this guy.
Yeah.
And I said, we need that voice with us. And so Eduardo and I became fast friends. We obviously launched the Spanish language hotline for Lifeline. And he's been, and the entire lived experience movement has been critical to everything that we have done. It's essentially the lost survivors tell us why we need to do this work to prevent suicide. But the survivors who have gone through suicide attempts have really taught us how to get through it. Yeah. And that's been a crucial voice for us throughout.
Beautiful, John. John,
Absolutely.
those three areas that Richard mentioned and you're building on, they were evident from the very beginning. And, that's how you and I met for the first time is talking about the potential when we saw Bob Glover and Nashbit in that proposal and heard those initial presentations from Maddie, John, and Brian, really breakthrough. Richard, let's jump ahead. And that was a phenomenal.
Well, one other thing before we jump ahead, David, I'd be remiss if I didn't mention another key thing that happened during that era.
Yeah.
Which was in 2007, the establishment of the link with the Veterans Crisis Line.
Yes.
The Press One option. That was a really important step forward in terms of our nation's veterans. And it also, I think, the notion then of the embedment of the Veterans Crisis Line within the VA healthcare system, was also a really important marker. And, there are some people who really deserve credit during that time who people may not be familiar with today. For example, Jan Kemp was the key person in making that happen, along with Ira Katz, who was head of the VA mental health at the time. But it was Lifeline who made that link occur in a very short period of time. Yeah. It went from an idea that was first communicated to us in April of 2007 to go live in July of 2007.
Yeah.
And that was important also because it meant there was a single national number. There wasn't a separate VA suicide and a hotline and crisis line and another one for the rest of the nation.
Right.
No, there was one that was together.
Richard, do you remember how that happened? What Jerry Reed said? Jerry Reed, the VA naturally, in most cases, likes to do it their way, in their own way. And the idea of saying, we're going to use SAMHSA's line seemed, I think, to some perhaps preposterous. But Ira Katz and Jerry Reed got together and Jerry said, Ira, there needs to be one number for all people who are in suicidal crisis. That's what the Veterans Crisis Line should be all about, is because that's what veterans and military folks fought for, is to do something for everyone here in this country. So there should be one number for all Americans. And he said, that's it, let's do it.
And Jan Kemp also, Richard, was such an innovator with chat and text at a time that was just not something call centers were open to, and VA open sourced all their policies and procedures. Let's jump to this the era that we're in now, Richard, and really starting in 2019, 20, in that period where we begin to identify that we're going to have a national number. We don't know what it is. Richard, it's going to be 211. It's going to be 611. No, it's going to be 988. And you're leading the effort with SAMHSA and the VA to put reports through to the FCC and Congress. And you begin to see the vision and potential. Talk about that, this exciting transformative era that we were in as we're leading up to the launch of 988.
Yeah, so one of the heroes who deserve recognition, possibly the one indispensable person leading to 988 was Steve Eleazan a state representative for the state of Utah.
Yeah.
And in Utah, they had the idea that they wanted a 3-digit number for suicide prevention. They looked into it and they said, no, that can't be done. Anything has to be national. And then Steve and his colleague in the Utah State Senate, worked with the Utah congressional delegation to pass the first legislation, the National Suicide Lifeline Improvements
Orrin
Act.
Hatch.
Yeah, they worked with Orrin Hatch.
Yeah. So that act required that both SAMHSA and the VA needed to do a report to the FCC, and one of the FCC's advisory committees, one of their formal federal advisory committees, also needed to do a report to the FCC on whether a 3-digit number was feasible and desirable. As part of that, SAMHSA was also asked to speak to the effectiveness of the lifeline.
Right.
Well, we were able to rely on the extensive set of evaluations to document the effectiveness of the lifeline. But what we also said in that report were, I think, 2 key things. One was that we agreed with those who were saying that a 3-digit number would lead to more utilization. The example that we gave in our report to the FCC that they in turn used in their report to Congress was that if you had a family member experiencing chest pains, it's likely that both the person who's experiencing the chest pains and the family member are going to remember the number 911, but that it was unlikely that in a suicidal crisis that a person going through that or a family member is going to remember 1-800-273-8255.
Right.
So we indicated we thought this was really important to increase access for people who are in crisis. But we also thought that a 3-digit number could play a transformative role in catalyzing change in the behavioral health crisis system in much the same way that over a period of decades, 911 was a catalyst for the evolution of the emergency medical system within the United States. So those were 2 of the main points that we made. There were a number of numbers that were being considered at that point in time. The FCC took all of that in consideration, and when they made their report to Congress, they recommended the number 988.
Richard, one other story, as we just today focus on the history side, is the impact of COVID and the what you launched in a call to me, and in the gosh, it was probably March or April of 2020 that ultimately became the 988 Learning Community, the Crisis Jam. Talk a little bit about that story, Richard.
Sure. So at the start of COVID, obviously, it was a time of great turmoil, tragedy, anxiety there, and it was having a pronounced impact on a whole range of mental health services. And so, in those early weeks, one of the things that I thought needed to happen is that we needed to have a way of getting a pulse of what was happening in our behavioral health crisis system because of COVID. So I spoke to our CMHS director, Dr. Anita Everett, and told her that I wanted to get people together on a call so we could try to assess what was happening in crisis services around the country. And that was what we did. And we brought people together and got updates. And there were a number of things, of course, that were going on at the time. Call centers were in the process of trying to figure out how to go remote rather than bring everyone into a central location, which was, the way things were most typically done at the time. Mobile crisis teams were trying to figure out how to do their work. How much could they do on the phone? And then things like crisis stabilization units, but also inpatient units, were having to deal with how do we provide care for people together while containing the risk of infection, which typically meant that the bed utilization had to be reduced in order to reduce the risk of infection. So those early weeks in the first couple of months, that was really the focus until it became apparent that the crisis system was still, like the rest of the country, having an impact by the pandemic.
Yeah.
But it was still there. It was still existing. The other thing that was happening, particularly, for example, in places like New York City, was that there was a real emphasis on keeping people out of emergency rooms.
Right. Of course.
And for utilizing alternatives. So those are some of the key things that were going on. But that was the genesis of the crisis jam, with those calls that were started. And then, David, you played an instrumental role in growing that over time and engaging folks from around the country, and making it the go-to place for learning about what was happening in the crisis services world.
So, John Draper, what a long and winding road it's been. I want to, as we get to the end here today, our sponsor of this program is Behavioral Health Link, and back when, Richard, you were talking about those initial period of the Lifeline and working with John, having Bob Glover at the table in the States, Georgia had an amazing integration concept and design. But Richard, what was your first? Did you come and visit Behavioral Health Link in those early years? Do you remember the first time you came to Atlanta?
I don't remember which year it was, but yes, I came early on. I mean, David, you co-chaired the Lifeline Steering Committee in some of those years, so you invited me to go visit Behavioral Health Link, and it was like glimpsing the future. I was so impressed by a lot of the dashboards you had. And when I went back to SAMHSA, I took one of the dashboards and I put it on my door for people to see, what was possible, the metrics that you were using, etc. And as I would give talks in different places around the country, I would point out that in Georgia, it was the only state that I was aware of where if you were in an emergency room at 2:00 in the morning late on a Saturday night and you were being discharged, you could actually get an appointment in the community mental health system because of the fact that the Georgia Crisis and Access Line was able to give appointments. So standard care in an American emergency department would typically have been, here's a number to call.
Right.
And then leaving the person on their own.
Yeah.
But in Georgia, it could be, here's your appointment. And that was a really important, innovation, there, among others that were part of what the Georgia Crisis and Access Line brought to the country, including now that our 988 Office Director, Monica Johnson, who oversaw that as part of her work in the Georgia Department of Mental Health.
Terrific.
Well, that's kind of what you're describing in some respects, though. The success and innovation of what Georgia was able to accomplish. The secret sauce really was in having this communications technology that really made a huge difference, Richard. So I appreciate you mentioning all that because there's nothing that's going to help move us forward better and more so than connecting our systems of care through a communications platform. I wanted to ask you, since we spent a lot of time talking about what has happened, and that includes now we've launched 988, you're also involved in the National Strategy for Suicide Prevention's second revision. It's the third version overall. Should be coming out any day now, I would imagine. But the idea of that is to chart a course for suicide prevention for the future. And it's building on things we've already done and also some things we haven't done. And I'm wondering, as you've been working on that and really getting the grand scope of the road ahead, when you look at it, are there aspects of the national strategy that you look at that you think are going to make a huge difference, perhaps the biggest difference in preventing suicide going forward, something that hasn't happened yet that you'd like to see happen that the national strategy may help us accomplish?
Yeah, so I would mention a couple of things, around that. When the national strategy is released, and again, as you said, we're hoping that that will be soon. We anticipate it will. It will be accompanied by a federal action plan, right? So this is something that has never occurred before, right? That the 2001 strategy was released. The hope was that there would be a National Action Alliance to oversee its implementation. That actually didn't happen until 2010. But then the Action Alliance was able to play a crucial role in the second national strategy. But for this national strategy, this will be released with a federal action plan with commitments from federal agencies and departments across the government and for a whole of government approach, with a series of commitments of what these agencies and departments will be doing to promote implementation of the national strategy. I think that that's really groundbreaking because that's something that has not happened before. I think that another thing that I would mention is that I think the emphasis on crisis services, you'll see, will be stronger than previously. There was nothing about hotlines or crisis services in the 2001 national strategy. The Lifeline was referenced as part of a couple of different objectives in the 2012 strategy. But I think you'll see when the national strategy is released that there will be an even stronger emphasis on the role of crisis services.
Great stuff, Richard. Thanks so much. It's time, John, for some plain truth. Reflecting on historical events often offers valuable insights into the evolution of societal systems. Such is the case with the emergency response for John Lennon's tragic shooting in 1980. At the time, in the heart of America's largest city, despite Lennon's global fame and the establishment of 911 emergency calls almost a decade before, the immediate medical response available was shockingly inadequate by today's standards. Instead of an ambulance, 911 at the time was most often forced to engage bystanders, family members, friends, and frequently coroner's vans and hearses were used. With John Lennon, it was a police car that rushed him from the Dakota right off of Central Park to the hospital. What an example of the lack of immediate, on-the-scene medical care and transportation capabilities for that era. Fast forward to the present. What does it look like when we're in our living room and we find a parallel in the handling of mental health crises? Let's go to that next slide. Despite the introduction of the 988 crisis hotline, designed to offer a specialized response to mental health emergencies, the predominant in-person crisis response remains rooted in law enforcement. If I call a friend and share my suffering and pain, it's likely they call 911. And most communities simply don't have the capacity for a mobile team to respond. It's more likely police will come to my home and take me to a hospital emergency room. This method often results in 70% of individuals in crisis being handcuffed, transforming a moment of acute personal vulnerability into an experience that feels and looks like an arrest. We've launched 988, and now we need the ambulance. We need not just the ability to respond on the phone, but we need mobile teams that can be there in person. We've hired the police for public safety, not to transport medical or mental health emergencies. We need mobile crisis teams in every community, metropolitan and rural, to respond with mental health crisis intervention that genuinely feels like compassionate care to those in distress. John and Richard, that's some plain truth and a real lifeline.
Thank you, David. And thank you, Richard. And y'all just be sure to join us next week when our guest is going to be the guardian of the Golden Gate Bridge, former California Highway Patrolman Kevin Briggs. So in the meantime, let's stay cool, stay anchored, and look out for the lifelines that we toss your way next week. Take care now.
Take care.